Hello, hello, and welcome to the Feeding Pod. This is your host. I'm Brianna Millick, and I am a speech language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So, without further ado, let's get into today's episode. Hello, and welcome back to the Feeding Pod. This is Bree here, and today I am accompanied by Dr. Catherine Sanchez. She is an absolute amazing human, so passionate, so kind. I feel like I could laugh and talk with her all day long. And in today's episode, we are going to be discussing tongue ties and what the research shows us, as well as some case studies to bring that information to light. And so sit back, and I hope you enjoy this episode as much as I did with the amazing Catherine Sanchez.
My name is Dr. Catherine Sanchez. I am a speech pathologist in Melbourne, Australia. I completed my PhD looking at oral motor concerns in children born preterm, and I now work in private practice 2 days a week, mostly with children 0 to 6, a combination of feeding and communication concerns. And I am also the pediatric medical editor for the Informed SLP, which, for those of you who don't know, is a website that reviews the current evidence for clinical speech pathologists.
Yeah, and they are wonderful. Highly recommend joining in on the Informed SLP. But thank you so much. And so I'm really excited to have you here today because we're, of course, going to be talking about the ever ongoing hot topic of tongue ties and just presenting like what is the evidence around it? What is it? What's our role as speech language pathologists with that decision making? And then also talking through some cases, which I think is a great way for all of us to learn. So to kind of dive into it, let's go ahead and start with just, what is a tie?
And this is a great question and not as easy to answer as it should be. So I think it's really important for us all to realize that there is no broadly agreed upon definition of any kind of tie. Tongue tie, lip tie, cheek tie. We don't have a really solid definition that everyone agrees is actually a tie. And definitions can vary a lot. So some people, when you're in discussions online or even in workshops, you'll see some people using the word tie as synonymous with just a frenulum. So, this child had a tongue tie that, wasn't affecting function. And what they actually mean was this child has a lingual frenulum that is, or that I can palpate. And so that would be sort of on one end of the spectrum of definitions. And then right up on the other end would be a frenulum that is so unusually tight and also unusually short that it has a substantial impact on the function of the structure. So the function of the tongue, the function of the lip. And so we haven't got good agreement, but I think everybody probably has their own internal idea of what their working definition is. And for my purposes, I tend to use the definition of a frenulum that's so short and tight that it substantially affects function. So Brie, I don't know where you come down on that.
Yes, absolutely. And definitely that it needs to be something that is functionally indicated and that it's not something that's my biggest thing, my kind of spiel is that it needs to be something that isn't just because of a lack of exposure or for a lack of practicing a skill, because I think that's something important to consider as well. In evaluation or something, you're like, oh, they can't lateralize it, they can't stick it out. And it's like, well, maybe they haven't had enough practice with that, or they're not really sure the skill you're trying to get them to achieve. And so sometimes, I think it's difficult to, in that initial evaluation, figure out if a child truly has a tongue tie going on in there. And that's where, again, it goes into the function.
Yeah, absolutely. And yeah, I'm thinking of a little guy that I assessed earlier this week where he came in and, he's 10 months and he's not lateralizing his tongue. But, when you go into the history, the only way he's getting purees is syringe fed into his cheek. So, he's not
He's
getting
just
that.
swallowing, doesn't have to. Mm-hmm.
Exactly. So he's still got that backward and forward movement and yeah, he just doesn't need that more sophisticated tongue movement yet. So yeah, it's
Right.
Definitely important to think about other differentials, I think, when we see that impact on movement.
Yes, absolutely.
So, I mean, we can look at anatomy as well. And obviously, this is an anatomical phenomenon. And so we need to think about the anatomy. And there was a really interesting series of studies that started coming out a couple of years ago. And I know I can see you nodding.
Yes, I know these articles.
I love them so much. I just think that they were absolutely game changing. So if you guys want to look them up, they're by an ENT, an otolaryngologist, called Nikki Mills, Dr. Nikki Mills, who is a New Zealander, and she did cadaver dissections. So she has a paper on adults and one on neonatal dissections as well, where she actually went in and had a look at what we're seeing anatomically when we're talking about ties. And so there has been this sort of dialogue for a long time that, a tongue tie is a string or a tongue tie is a band, or, but what she actually found is that the lingual frenulae is a medial fold of fascia. So fascia is the connective tissue that surrounds muscles and compartmentalizes muscles. If you eat meat and cook with meat, it's the really tough stuff on the, when you're cutting up meat, that sort of tough whitish stuff that surrounds the meat, sections of the meat. So the lingual frenulae is a fold of fascia, and that fascia runs across the floor of the mouth, and it suspends glands, vessels, and muscles. So it has an important function in the mouth. And when you lift your tongue up, it folds up in the middle, and that's where you get a frenulum. And she also found, because she did histological studies, so she looked at the tissue in lots of detail under a microscope, and she looked at the different types of fibers and all sorts of different things. And she found that the variation that we see in frenulae is explained by lots of different anatomical variables. So there's the thickness of the fascia, there's the length of the fascia, there's where the fascia attaches to the jaw and where it attaches to the tongue, which can both vary, and there's the proportion and number of fibers of different types, elastin fibers and other types of fibers, that determine how elastic and sort of movable that frenulum is. What we can take away from that and all of that variation is that you can't look at a frenulum and say, oh, it's attached near the end of the tongue and therefore it's a tongue tie, because it could be one that's attached near the end of the tongue but is really, really elastic, or it could be one that's attached at the middle of the tongue but is really, really rigid and not elastic at all. So there are just so many variables that I think, we need to consider when we're looking at this anatomical structure.
And I think that goes into, which I've talked about on other podcast episodes, is the range of normal. That it's not just black and white. It's not just normal, abnormal. There's a huge range of normal that is acceptable for functioning and for completing the tasks. And so that's why, again, it's important to think, like, what is the skill we're targeting? And again, if we think about, well, the child's never been able, has never had the experience of chewing solid foods, I would not expect them to have that skill yet. And so when we think about that normal, the range of normal, there is variability that's going to occur.
Absolutely. And there's variability both in anatomy and what things look like. And so we just need to look at a lot of mouths to calibrate our observations. And there's also variability in physiology and function.
Yes.
and the way that people move and the way, we know, for example, from the articulation research, that there is a percentage of people that produces their sound with their tongue behind their lower teeth instead of behind their upper teeth. And they get a really functional that way. And that doesn't mean that it's disordered. It just means that it's a different way of producing the same sound, and they get really good function. So I think it's good to keep that definitely good to keep that framework of individual variation in mind when we're thinking about anatomy and physiology. And I think, the other implication of all of this information about anatomy that we've got from these fantastic studies is that the way that tongue ties are anatomically classified by a lot of people. So when we talk about an anterior tongue tie or a posterior tongue tie, or, you know, what the point of attachment is, or the size of a tongue tie, or like a tongue measurement, that those anatomical variables are not always particularly useful because there are so many other variables at play. And unless you're, you know, going to be quantifying the proportion of elastin fibers as well as the point of attachment, you know, there are so many variables that it's really hard to draw any useful therapeutic or assessment data from that.
Absolutely. And I think that's why too, which we'll talk about, you know, our decision making and other variables, is that, you know, it's not necessarily in our scope to make that decision either. And I can speak from, you know, ASHA in that, in an anatomical variable and like cleft lip, cleft palate, yes, we can say we see signs or symptoms, or, you know, function is impacted, or this may be going on, but ultimately the diagnosis needs to be done by a physician.
And yeah, and I think this is one of those areas where working as part of a team is so critical, and having a really good relationship with your ENT colleagues and you know, your lactation consultant colleagues and potentially dentistry colleagues, and you know, there are lots of other professionals that I think have to be part of the team for this. We can't be, you know, standalone therapists or standalone diagnosticians here.
Yes, absolutely. So going off too, with which we kind of talked about, you know, we talked about the functional impact of the tongue, and then there's the lip movement too, because we know lip ties is a thing as well. So can you speak to that a little bit too?
Yeah, absolutely. And I think, yeah, really, we don't have a solid definition of tongue tie, but we have even less of a solid definition of lip tie, unfortunately. So we talk about it being a frenulae between the upper lip and the upper gum, although some people talk about the lower lip and the lower gum as well, and that frenulae that, you know, if you have a palpable one, you'll be able to feel it with your tongue. You can take a second right now just to feel around there and see if you can feel it. And so the theory or the hypothesis that some people have is that you could have quite restricted lip movement if you had a really tight frenulum between the lip and the gum. And so in particular, people are interested in that as it pertains to breastfeeding. There has been a perception that children's lips need to flange on the breast. We do know now with new breastfeeding research that is not actually the case. You don't need a flange, you just need a neutral lip position. But you know, potentially people are concerned about the impact of a lip tie on breastfeeding. There's some concern about whether it might impact dentition, bilabial sounds and things as well. But we have sadly not a lot of evidence at all around lip ties. It's really, really limited. So that is still very much an area where we're waiting on the evidence.
Yeah, absolutely. So going into, you know, moving into more of the state of the evidence around ties. So we're talking about, you know, there's very limited evidence, but what of the evidence that's out there, you know, what do we kind of have?
So we always talk about different levels of evidence and different qualities of evidence, and you know, not just because it's published in a peer-reviewed journal doesn't mean it's you know, always worth changing your practice. And so the tippy top of the pyramid is randomized controlled systematic reviews of randomized controlled trials, or meta-analyses of randomized controlled trials. So just for those of you who aren't super research savvy, a systematic review is where a scientist looks at all of the research that has been published around a broad topic, and then they synthesize that into one set of outcomes. And a meta-analysis is where they do that, but they use that and sort of pull all of the numeric results into one single result, so that they can say, look, you know, there have been hundreds or thousands or, you know, 2 studies on this, and this many participants, and this was the change we saw, and overall this was the sort of result. So we like those because they reduce the risk of bias. They increase the power, which means that we have more participants because they're looking across studies. And so we do actually have some systematic reviews of RCTs and some RCTs in this field, and mostly they're on breastfeeding. So we have some evidence at that level that tongue tie revision for some children can improve some breastfeeding variables. And in particular, maternal nipple pain has some good evidence around it, breastfeeding self-efficacy. So the breastfeeding parent feeling like they're really competent with breastfeeding. So it does seem like for children with a significant tongue tie that surgery can make a really important difference to breastfeeding.
Yeah.
We have lower levels of evidence around whether ties have an impact on bottle feeding, eating or drinking solids, or cup drinking, and speech. So there are lots of studies and they go both ways. So you'll find some studies that say there's no impact on speech and some studies that say, yes, there is an impact on speech, which is why this is so confusing and such a confusing field for clinicians to work in, because we don't, other than that relatively solid evidence that yes, tongue tie can affect breastfeeding and revising it can improve breastfeeding, there's not a lot that's consistent other than that, unfortunately.
Right. Yeah. And that definitely is one. I think that's why this area becomes so, hot and controversial, because depending on which part you're reading, you might be like, oh, yes, this totally makes sense. And then there's the other side that's like, no, absolutely not. And so it can be very, very difficult. And, how do we as clinicians make that decision? I think that kind of goes into, again, what we've talked about with, functionally looking at the whole child, working as a team, and all of those things are going to be really, really important.
Absolutely. And I think, there was a paper last year or the year before by Sharon Smart and her team in Western Australia, and they looked at a group of children who had been diagnosed with tongue ties as babies, and some of them had had the tongue ties operated upon and some of them hadn't, and they found that a few years later there weren't differences in those children's speech. And I think that was a really interesting paper to look at, because while there were some methodological issues that mean that we can't extrapolate that to mean that tongue ties don't impact on speech, I think that what that and some of the other evidence says is that we shouldn't be making decisions prophylactically. So we shouldn't be making any decisions to prevent functional issues, possible functional issues in the future. So when a parent says, do I need to get my child's tongue tie snipped so that their speech will not be affected? Our answer is no. We need to see whether it is affected before we make a decision one way or the other. Do you get that in your clinical practice? Parents saying, oh,
yes.
Should I do this?
Yes, absolutely. And I think too, sometimes they will come in being like, okay, like I'm pretty sure my child has a tongue tie, and they come in for that. And then what ends up happening is we just needed a positioning change, or we needed to use some other modifications to help them, figure out how to lateralize and chew. And then they're like, okay, well, the dentist still says that there's, a tongue tie. Should we go ahead and get that done? Because what about speech, or what about this? And so I think too, within the caregiver world, that's where it's, our responsibility as well to provide them with, the ultimately, like, this is what the evidence shows, and this is what I can tell you. And if the dentist is concerned from a dental standpoint, that's a decision they need to make, and not one that's going to be on us either. And I think same way, if they're like concerned about, oh, well, is it going to affect their sleep or their airway? That's a decision that needs to be made by the ENT then. I'm not going to be making that decision. I'm just looking at the speech and feeding skills, and that I'm not going to recommend this in order to prevent something that may not ever occur.
Yes. Yeah, absolutely. And I think that that's such a good point around that scope of practice issue. And because I think, people are making links into lots of different areas for ties, we are getting asked about things like dentition and breathing and sleep and things that are very much as SLPs that are outside our scope of practice. And, there are some SLPs who have got additional training. And so they might be acting in a different role and giving parents advice about some of those other variables. But if our training is as SLPs, we need to be sticking to talking about speech and feeding, because that's where our scope of practice lies, and then directing patients and parents to the relevant professionals or the relevant information if they're looking for sort of other data. And there have been consensus statements from the Australian Dental Association and from the American Academy of Otolaryngology, Head and Neck Surgery, both open access, so they're available for free to everyone. And I find those quite helpful for if parents say, well, what sort of impact does tongue tie have on dentition? I can say, look, I'm not a dentist, but let me give you the address for this information, have a read and talk to your dentist about that. I think that's a more fruitful discussion than me trying to speak to
work my way around that.
Exactly. Yeah, that's right. We've got a plenty big enough scope of practice without trying to include a bunch of other stuff in there too.
Yes, absolutely. So something else I think as well that can sometimes be overlooked is some of those contraindications, as well as like the possible risks of having having a tongue tie release.
Absolutely. And I think a lot of people and a lot of parents as well, it's I think referring to it as a snip can sometimes be a little bit problematic, because parents are like, oh, it's just a snip. Like it's fine. It's just
quick. It's quick and easy. And
yeah, that's right. It's like getting a haircut, like trimming their nails. Although, for my kids, trimming their nails.
Yeah. So we are comparing it. So maybe
exactly. A bit deep there. Yeah. So and there are studies documenting that there have been adverse outcomes, and they're rare, but there have certainly been adverse outcomes documented, and they can include things like hemorrhage, infection, which can be an issue with any sort of surgery, damage to underlying structures, and I think maybe we don't consider that one enough. So we know from Nikki Mill's wonderful study that there are salivary ducts and nerves very closely underlying the flora of mouth fascia, and there has been some sort of speculation that if you're cutting into the frenulum, you might damage those sublingual nerves, which could be a real issue from a functional perspective. And in particular, one of the things that the paper talks about is the fact that laser frenectomy, you get absorption of that heat energy into surrounding tissues. So even if you're not directly cutting into a nerve, you could still get damage to the nerve because the heat is just traveling further than where the cut has been. So I think some of those are worth considering. And then particularly from our perspective, oral aversion, I think, is probably a really underdocumented risk here, where, especially for kids who are already having difficulties with feeding is already stressful, and then we're going in and doing surgery on their mouths, and potentially with these sort of aftercare routines that are being recommended now, just a lot of re-traumatization for parents who are very diligently doing the stretches every 3 or 4 hours for weeks on end.
Sometimes more. I've even heard more frequent recommendations, and I think that's a big one that is often misinformed to parents, of that. No, it's definitely not going to make anything worse, so why not? Unfortunately, I think that is often how it's portrayed, and the thing is, it could be worse. I always, when I'm talking to colleagues and other friends about like trauma's perception, so I cannot say how a child is going to respond to this procedure, because their response could be 100% different than another child's, because how they perceive it is their response to it. And so I think that's something that we really need to really be cognizant of and think about, which is, why when we are talking about these decisions, thinking about all of these factors.
Really important. And I have a little bit of training and a little bit of experience in infant mental health and an interest in infant mental health. And I think that, traditionally we have had this perception that very young babies might not experience pain in the same way that we do. And we think about doing things to babies, and we don't really think about their internal states. And I think that we need to, in this area, we need to think a lot more about how this is perceived by a baby and how it feels to a baby. And I just think about a little girl that I saw last year, who, she was 3 weeks old. She was the first birth child of her mother, but the mum had another child by her partner. And this little baby was having issues latching. She'd been slow to gain weight. And so she'd been referred straight to a preferred provider. The preferred provider had lasered the tongue tie, the lip tie, and cheek ties,
which we didn't even touch too much on. There's nothing in there.
There's nothing. But I actually did a literature search a little while ago, because I was like, has there been anything? And there are maybe like 2 or 3 mentions of it as a concept, but no evidence that it's an issue or that it has any impact on function, which I think is really interesting. So yes, this baby had all the frenulums lasered. There had been no immediate improvement in breastfeeding. This mother had been doing stretches 4-hourly day and night for a week. The baby was extremely distressed during the stretches. The mother was extremely distressed during the stretches. The other mum and the other child had to leave the room when it was being done, because everyone was just finding it extremely traumatic. And there was no change to feeding, a week and a half after this frenectomy. And so I did my assessment, and, you know, this baby had quite a shallow, inconsistent latch popping on and off. And mum was just really distressed and stressed out during feeding, which is completely understandable. And so my recommendation was, look, I know you've had this frenectomy and you don't want it to you don't want scar tissue, but I want you to stop those stretches, because I just think that they're doing a lot more harm than good at this point. We tried a position change, and we talked about introducing some non-nutritive sucking. So just sucking on a finger or sucking on a dummy, and keeping that as a really sort of calm, gentle experience. And I said, you know, look, if this is persisting, we'll check in with a pediatrician and see how that's going. And I think in the US, your babies see pediatricians a lot more frequently. Yeah. So in Australia, you would only go to a pediatrician if you actually have a concern. So early
check-ins a lot more frequently early on.
Okay. Yep. So we have professionals called maternal and child health nurses who do that surveillance job, where they see babies frequently in the early stages, and the ped is only if we are worried. And then so I checked back in with this family a week later, and they were getting improvement. So things were going better. She was taking feeds better. They were feeling more relaxed. And then I checked in another week, and everything had resolved. It had all come good. She was feeding really well. She was gaining weight. The parents were more relaxed. And it just made me think a lot about that infant mental health piece of things, and the harm that is being done to the parent-child bond when the parent is traumatizing that child every 3 hours or 4 hours for weeks, and how difficult that must be to overcome as a parent.
That's what I was going to say. And that's the part, I think, again, that just like the parent-child bond is so important and can be overlooked in our littles and our older children. And that dynamic and the dyad and the communication between them is so important. And I think, you know, that is also something that can be very distressing, because if the caregiver is distressed, then the child is going to follow suit. So
exactly. And we know how sort of far reaching some of those impacts on relationships can be, and that, you know, that the parent-child relationship is one of the most protective and important factors in early childhood. And I think we need to be really careful about considering that as a risk.
And that we do have lots of research on.
Yes. Yeah, we have
the
so
caregiver-child relationship is huge.
Yep, absolutely. We're not lacking in research there.
Yes. So going off, and that case study, I think is a great one to kind of think more about, you know, when we do see a patient, you know, how should we treat them? How should we move forward? Even if, you know, maybe we are suspecting that there could potentially be a tongue tie, you know, what would be the best way to move forward?
Yeah. And I think we need to treat, when we don't have evidence, really good evidence, I think it's really important to treat every patient like they're an individual case study. And so, you know, when you first see a child, I think, you know, we go through this process of forming hypotheses. So, you know, here's a baby that is, you know, that has a poor latch and is not sucking well. So one of our hypotheses might be tongue tie. One of our hypotheses might be maturational factors. One of our hypotheses might be, you know, neurological damage, depending on the child's history. One of our hypotheses might be, you know, difficulties with fit and hold, which are, you know, really key sort of breastfeeding variables. And so, you know, we've got these hypotheses, and then I think, you know, we need to consider, are these hypotheses possible? Is it possible that they're causing the feeding problem? And I would say that in all of those cases, yes, it's possible. And then how plausible is it? So, you know, and how probable is it? So we think about, for example, we know that fit and hold problems, particularly in first-time mothers, explain a huge percentage of breastfeeding issues. And so the probability of that hypothesis being the correct one is quite high. If the child has no medical history, the probability of a neurological injury or deficit explaining the sucking problems is pretty low, because there's, you know, we don't know that they've had preterm birth or neonatal stroke or brain injury or anything along those lines. So I think explicitly thinking about these as these are my hypotheses, and this is sort of how ranking those hypotheses from most to least likely, I think can be really helpful. And then you have to go on to test those hypotheses. So, you've got this hypothesis that, okay, well, maybe this breastfeeding problem, this latch problem is being caused by a fit and hold issue. If that is true, then making a change to fit and hold should improve feeding. And so, we go in, we make the change to fit and hold, and then we see, does it improve feeding or does it not? If it does, then our hypothesis is upheld. Okay, it was at least partially a fit and hold issue. If it doesn't improve, we go, okay, well, no, it wasn't a fit and hold issue. So let me go to the next hypothesis on my list and let me test that hypothesis. And I think having that really scientific process can be quite helpful, particularly with tongue tie, because I think it is a legitimate hypothesis in a lot of cases. We know that it makes a difference to some breastfeeding babies. And I think that it's plausible that it makes a difference to children with speech and other feeding issues as well, because we know that, how important lingual movement is there. But I just think that we need to make sure that we're thinking about other hypotheses and other possibilities and testing them out. So I'm thinking about a little guy that I saw who I will call Lachlan, and he was 5 years old, and he had been to several different speech pathologists for chewing issues and gagging and a mild speech sound delay. He wasn't a picky eater, but he just, when it came to meat and things, he would gag and have issues with it. Neurodevelopmentally, there were no other concerns. He was doing really well. He was a bright, happy little guy. He came into the room and was very active and talking to me, and was fascinated when I showed him like my Mighty Mouth puppet, and was talking about what the different things did, which was lovely. So I I was doing this assessment with him, and I was formulating some hypotheses as I went along, and because of the population that I see, I'm like, chewing difficulties, gagging, like one of my major hypotheses is going to be that this is sort of a sensory feeding issue. We got out a few different foods. He dived right into them, very happy to touch them, put them in his mouth, like whatever. I introduced new foods. He had no problem at all. I'm talking to his parents. They're like, he has no like dietary restrictions. I'm like, okay, this hypothesis not upheld. Definitely not a sensory feeding issue. I'm like, okay, well, neurodevelopmentally he's normal. It's less likely to be like a neurologically based issue. Let's just have a look at what he can actually do with his tongue. And so we did an oral motor examination, and I was getting him to lateralize tongue, so tongue to each corner of your mouth. And his tongue was actually folding in half to try and get to the side of his mouth, because his frenulum was so short and tight, he couldn't move the middle of his tongue. He could only move the sides. So he was folding like one
pull that side all the way over.
Exactly. I was like, whoa, that's intense. And then I was like, okay, try and touch your nose with your tongue. And he had almost no movement in the superior plane. And I was like, okay, well, let's look at you chewing. And I watched him chewing, and he couldn't manipulate the bolus at all. He had basically no lateral movement, basically no superior movement. Of course, he's going to struggle with meat. And so it was a really nice sort of example, I think, of a process of going through testing a few different hypotheses in an assessment. But we know that I can't make sort of that assessment by myself. So my next step to test my hypothesis that I think this is a tongue tie that might be affecting chewing was to refer to an ENT who could assess airway, who could look at sort of general anatomy and general function.
I love too, I just want to note in your assessment where you had him lateralize his tongue, you had him try to elevate, but then you still watched him chew. So you still watched it in function. And I think that's so important, because oral motor assessment in isolation still might not tell us all the information we need. And we need to see it during the actual task at hand.
Yes. And I think probably what pushed that over the line for me, it was in my PhD, I probably did about 150 oral motor exams on 3-year-olds. And 3-year-olds, like 80% of 3-year-olds are terrible at imitating oral motor movements outside of a
They've never had to do that before.
They haven't. And so there's like jaw sliding all over the place. There's like extraneous head movements. And these are, at least half of these were totally typical, no developmental issues, like typically developing 3-year-olds who just couldn't imitate oral motor movements. So I think it's really important to always look at functional, because you can see you can see changes in either direction. You can either see that they've got much better skills functionally, or you can see that they can't coordinate things functionally. As soon as you put that movement into a functional context, they just lose it. So yeah, I think that's such a good point to sort of emphasize. So yeah, this little guy went off to an ENT, and the ENT was like, wow, I'm surprised that you can talk with that tongue tie. It is extreme. And so he was booked in for a frenectomy, and I reviewed them a few weeks after the frenectomy, and his chewing was on the improve. It wasn't completely better, but they were already seeing less gagging and more willingness to try chewy foods. And so we did a bit of functional therapy around, using the tongue to retrieve boluses laterally.
Like, where does my food go? How do I get my food?
Yeah, that's right. Like, can I move my food deliberately from one side to the other and chew on that side and chew on the other side? And, this is what you can do with neurotypical,
it's great when they can follow directions.
And so I've actually discharged him, and he's doing really well. He's got no gagging at mealtimes anymore. He's got full diet. And so in that case, I think frenectomy was the right decision for that child, but we needed to go through that process of eliminating higher probability hypotheses first.
Absolutely. And I think too, talking about getting that airway assessment as well, because I think that's another one too, when we're thinking about, risks and benefits. And if there is an airway compromise going on that we are not aware of, then releasing that frenulum could cause more harm. And so I think it's something for us to be very cognizant of when if we are going to be making these referrals, to, again, think of the whole picture and consider airway, because that is a huge part of a child's airway.
Massive. And, I know one of the contraindications that is often listed in the literature is around airway patency, and children with Pierre-Robin sequence who, their tongue often falls quite far back in their airway. And potentially if you remove that frenulae, which is anchoring their tongue into their mouth, they could end up with even less airway to work with, which can be really problematic. I think, we could end up causing harm in those kids. And that consensus paper I mentioned from the Academy of Otolaryngology.
I was about to say the same thing. Yeah.
So good. It's a really useful paper because it actually lists out what they see as some of the contraindications. And, I think with contraindications, it's always, it's not that a frenectomy will never, ever be appropriate in that case, but I just think you need to give it so much more consideration when you know that.
We need the team to help with those decisions. It's ultimately not our decision.
Yeah.
That's why we need those physicians. But and I was going to say from the consensus paper as well, where they talk about, that releasing a frenulum could actually then cause obstructive sleep apnea, versus a lot of times I feel that it's discussed in the opposite manner, that if there is obstructive sleep apnea, it's because the tongue can't elevate to lift up for breathing. And when really we needed to think about, just like you said, where, well, maybe if there is a slightly recessed jaw, or there could be laryngomalacia we're not aware of, or things going on that could then, almost exacerbate if there was any obstructive sleep apnea going on as well.
Yeah, absolutely. Or even cause obstructive sleep apnea that wasn't there.
Very
before.
Scary.
It is really scary. And I think, there are lots of clinicians out there being really considered and making these decisions really cautiously. But I know that when I first heard about tongue tie, I was not as cautious as I should have been. And, I was still working in a team and going via doctors, but I was being a bit too gung-ho with my recommendation.
And I will admit to that as well, like 100%, because when you first hear about it, you're like, wow, did I just have no idea? Or what, like
the puzzle that could fix these kids that haven't responded to treatment, and
dive more into the research and see more of what's going on, and start, really reflecting on what, your hypotheses, and testing your hypotheses, and using those less invasive interventions before you go to something like that. I think is huge, because a lot of those less invasive ones, in breastfeeding, even, for example, changing the positioning, changing the fit and hold, like if you just make that alteration, that might have been it. But if your brain immediately goes to this because that's, what's been newly introduced to you, then I think that's where the issue lies. So
yeah, absolutely. And I think, so many of the interventions that we use in our scope of practice are low risk interventions. You try, multiple oppositions with a kid for a couple of weeks, and if it doesn't work, then you can just back off and no harm, no foul. But, with something like a frenectomy, while we're making it, well, we're contributing to that team decision, and it's not just on us. There are very real risks apart from sort of, time and lost time working on something that doesn't work. There's other risks involved as well. Yeah. And I do think, I know I'm coming back to my case studies a lot, but I think
no, you're good. They're very helpful. They're very helpful.
I'm glad. I just, it's all about the kids I see, and they're what I always anchor my knowledge in.
No, absolutely. I agree. I think that's like a great point that, again, I feel like a broken record here, but like, what's the function? What are you trying to achieve with it? Think about that. And then you can go down from there. If you're thinking about function, you're thinking about that caregiver-child relationship. I think those are two really important things that you can't really go wrong in if you're really thinking that through.
Absolutely. I think, I don't mind you broken recording on function. I feel like tongue-tie is a functional diagnosis.
Yes.
Because so in parent groups, I mean, I have kids and I am in parent, and it's such a minefield for parents now, because, people post photos of their children's mouths and are like, what's going on here? And then like 5 people will say that's definitely a tongue tie. You should go to this dentist who will just snip it in the first appointment.
Yep.
And it's, none of it is about function. It's all about, anatomy and fear. And what they really need is somebody to, like us, or like, our team of professionals, to come in and go, okay, well, let's look at function, let's look at feeding, let's look at communication, let's look at airway, let's look at dentition. What are the functional issues we're seeing before we make any decisions about management?
Yeah, absolutely. Absolutely. So I know you have one more case study to kind of discuss, and then I'll share one that I've had specifically that is similar to yours, but child was a little bit older. So I'll let you go ahead with that one first.
Lovely. So this is, I feel like I'm my balance of case studies is a little on one side, and I will just emphasize that I see myself as tongue-tie agnostic, and that I have kids that I recommend frenectomy for and kids that I don't recommend it for. But I think because of the discourse in our field at the moment and the direction of that and the weight of that, I think it's important to emphasize sort of both sides and acknowledge both. So this is little Cleo, 5 months old. Mum was second time round. She had successfully breastfed the first time to 2 years with no issues at all. So very committed and dedicated breastfeeder. This little girl though, Cleo, had just issues breastfeeding from the start. It just never went well. And COVID world, I'm in Melbourne, where we had one of the most severe lockdowns in the world. Yeah. And lots of people couldn't access good supports during that time, which is really problematic. So this little girl, she had progressive worsening of her feeding from around 3 weeks. Mum was on the parent forums, and so she knew about tongue tie. And so she went and got her little girl lasered at 4 weeks. She did the exercises for 2 weeks, every 4 hours, day and night, and breastfeeding. She went back to the dentist, who had a formal follow-up program, and said, look, this hasn't made a difference, and feeding has actually got worse. And the dentist said, well, look, I'm just really confused by that, because that never happens for the kids that come through my clinic. And yeah, so Mum went through 3 IBCLCs, lactation consultants. She had
this mama's heart.
Oh, I know. She was just working, and it was the 3rd lactation consultant who said, maybe you need to go to a speech pathologist so we can check out the infant's oral function. But by the time she came to me, she was 5 months old, and and that's like 5 months of horrific just feeding. And so she was being fed by a syringe while asleep, and that was basically all of her feeding. And Mum was still expressing. It was all EBM. So Mum was just like constantly essentially feeding her. And this little girl, like, I had a look at her. She was clearly aversive, like lots of symptoms of feeding aversion. Based on the case history and based on what I was seeing, I thought she probably was just a little immature with her oral motor skills. So that I thought that was probably why she had the early feeding issues, and probably why Mum was concerned about tongue ties, because she was maybe seeing a real functional oral motor issue, but there was just no one to support her with sort of figuring out what else that could have been. So there was that dysmaturity. And I think, she'd had this traumatic intervention as well and the stretches. And then mum was force feeding her too, because you have to, because, your baby's not eating. And of course, that's what you fall in. So I sent this family to a mental health trained pediatrician so that we could manage the family jointly. I really wanted somebody who was very au fait with infant mental health. And this particular pediatrician was the consultant for infant mental health at our local children's hospital before she went into private practice. So I knew that she would be really looking at that relationship, which was lovely. I also recommended responsive bottle feeding with a slower teat. So the slower teat to account for some of that dysmaturity and obviously the responsiveness to try and reestablish that relationship. We started discussing reducing syringe feeds. Mum was very worried about weight. So that's why the pediatrician was really useful, because mum pediatrician could reassure mum a bit and say, look, let's just drop one syringe and see how it goes. And we're still working on slowly dropping those syringes down. And we also talked about starting to introduce solids. That was the pediatrician's recommendation, but then I gave mum support with how to do that in a really responsive child-led way. And where we're at now is, Cleo is really enjoying solids. She's just loving that. And mum is loving watching her loving that, which is so beautiful. They're sort of reestablishing that nurturing relationship with food. They've dropped one syringe feed. They tried dropping another one, but her weight came down. So they had to reintroduce that. But our aim is to get rid of syringe feeding entirely. Yes. Because I think we've talked about this before, Brie. Neither of us are big fans of syringe feeding.
No, we are not. We are not. It's definitely.
I love the syringes. Yeah. But yeah, I really feel like with this child, again, it was a real mental health issue overlaid onto some genuine, early oral motor problems. But if this family had infant mental health informed care early on, I feel like they could have saved 3 or 4 months of trauma for this mother and this baby. And, the mum, neither of them was sleeping. And it was just such an awful circumstance for them to be in.
Absolutely. Because I, as a caregiver, you're like, my one role is to make sure my baby's fed and gains weight. Everyone's like, feed the baby, just feed the baby. And so when things go wrong, thinking about that psychosocial side of not just what's going on in the trauma of the child, but also the caregivers really should not be overlooked in a lot of these situations. So
absolutely. And yeah, I think, if you are out there and listening and thinking, oh, this whole, infant mental health thing is a new world, there's lots of fantastic training out there that I think is really useful for us as feeding clinicians, because food is love, and food and feeding are so caught up in nurturing and nourishing and caretaking. So I think that's always really relevant.
Yeah, absolutely. So the one case I'll share before we kind of close is similar in that this kiddo had some breastfeeding issues. Mom had gone to see an IBCLC and things just weren't going well. She ended up switching to just bottle feeds entirely. Was doing bottle feeds and was like, it's okay. I mean, we cough a little bit, but I feel okay about it. And then she returned to that IBCLC, even though the child was just bottle feeding at this point, had returned to the IBCLC for just more support. She's like, it's just not going well. I don't feel like solids are going well. Because at this point, the child was 8 months old. And she's like, it's just not going well. And so tried to seek support. And so the IBCLC had at that time recommended tongue tie release and at a preferred provider. So went to the preferred provider, got the release done. And the pediatrician at the time had this whole time been like, you need to go see a feeding therapist. You need to go see an SLP. You need to go see an SLP. But again, mom was kind of caught into those groups of like, oh, my kid had this, it's a tongue tie. It's a tongue tie. And so she's just really concerned about that was maybe what was going on. So had the release done. We're doing all the stretches, and the IBCLC was kind of like, give him a little bit and he'll adjust to it. And thankfully mom was like, I figured I'd just listen to the pediatrician and maybe go get a feeding eval as well. So by the time the kiddo came to me, he was actually 10 months old and had the release done about a week before he came to me. And at this time we were just doing bottles and would do smooth, very, very smooth purees and nothing else. Anything else, we were gagging, aversive. We might mouth a little bit, but wouldn't swallow, had to spit everything out. And so I'm doing my assessment, I'm going through everything, and I'm like, oh, mom mentioned snoring. And I was like, oh, kiddo snoring. She's like, yeah, that's one of the other reasons we got the release was because, he snores and, concerned about airway and the tongue tie and all this. And so I was like, okay, well, has there ever been an airway assessment? And she said, no. And she also said that snoring stopped for a couple days, but then it immediately came back. And so I'm like, okay, interesting. So I recommend, okay, well, I think we should see an ENT. That's kind of where my brain is going if we are concerned about airway stuff. So went to the ENT, and in the meantime, we were working on open cup, straw cup, getting some of those things going and slowly introducing other solids. And sure enough, when the kiddo came back, he had laryngomalacia. And the ENT actually said it was some of the most severe reflux he had seen. There were sores in his throat. And so that's why he didn't want to swallow anything that had a little bit of texture to it. I know this poor bit. And it was interesting though, because mom's like, I would have never known he had reflux. He didn't spit up a lot or anything, but it's a silent reflux, and so that's why he would randomly cough a little bit, or you'd hear that gurgle, but he was extremely uncomfortable. And so he just wanted bottle to just push everything down. And so once, ENT made that diagnosis, we were able to be like, okay, where can we go from here? Started on reflux medications, and within 10 weeks he was completely self-feeding any foods around and just making huge changes. And so that's another kiddo where it's like you really need to think about the whole child in this situation. If mom's saying snoring, my first thought isn't the tongue tie is causing them snoring. That's why they're snoring, because a parent definition of snoring might be our definition of a stridor and laryngomalacia, and you're like, well, what does that sound like? What's that? What is the snore actually like? And so, I think it's really important for us to, again, look through all those. And in the meantime, while we're waiting for those diagnoses and those physicians, we can do some less invasive interventions to just promote a more positive meal time. Because in that situation too, mom was very stressed out because feeds were hard. Kid was coughing a lot, choking a lot. And once we worked on, okay, we're going to slowly go to open and straw cup. We're going to pace him a little bit. And then we're doing great. And I remember I followed up a month after discharge too. And she's like, yeah, we're good. All good. And so it's just, those are the best to hear, right?
Good. Where you're just the finger on the scales at the right time. And you don't need to do very much, but it just changes the trajectory so much.
Yeah, absolutely.
So rewarding.
Well, thank you so much for being on here and discussing all these things with me. I adore you, and I think you're brilliant and wonderful and do so much for our field, and it's really appreciated. So
thank you so much. It's been such a pleasure having a chat with you, and I love the podcast, and I'm super excited to hear all the other episodes.
Thank you so much. Well, I'm sure we'll be in touch. Is there anything else you want to share before we get off here?
No, look at function.
Yes, function. So we're blue in the face. I love it. Well, thank you so much. This was great.
Thanks very much.
Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow Bree, me, on Instagram at Pediatric Feeding SLP. Or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.